Hi, and welcome to Kosh TV on YouTube. My name is Janet, as always. Thank you so much for those of you who have been waiting to see another vlog. Thank you for your patience. Yeah, I needed to take some few days for some resting. Yeah, and then do a few chores as well. Okay, today I am going to talk about the some of the essentials of clinical practice. Basically, things that we do every day, things that come readily to you or may not, but things we need to actually take into consideration when it comes to being on the shop floor, when it comes to being in your clinical area, especially when it's direct patient care. Okay, so the first thing I'm going to mention, the first point I'm going to mention is pain management. Okay, let me put it this way. I'll be talking about pain management. I'll be talking about a bit about drug administration because that is quite something on itself. But I'm sure I'll be covering nearly everything in a concise manner. And then I will be talking about monitoring patients and how we communicate our informations with other members of the multidisciplinary team. So, pain management. Pain usually, when you are in pain, then it means something is wrong with the body. Or if someone complains of pain, you know that there's something going wrong. It's the first sign that tells you that there's something not right in most situations. So when someone comes to you, especially those of us, the front line staff, frontline staff, I mean nurses, doctors, anyone who deals with patients directly, okay? When you come into contact with a patient complaining of pain, what do? Obviously, when it comes to assessment, it's done by trained staff. So you, the non-trained staff, someone complains of pain, you report to a trained staff. You do not proceed to do an assessment. Of course, you can ask, where is the pain? But that's where it ends. If you want to be a bit more proactive, then you may proceed to do some observations if you are that trained. Probably the patient complained of a chest pain, then you can proceed to do an ECG, okay, if you are that trained. All right. So to my colleague, the trained health professionals, if a patient comes to you or you are confronted with a patient who is complaining of pain, it's something we do all the time. What kind of pain is it? Which part of the body is it? A patient cannot walk into, let's say, accident and emergency center and be in excruciating pain and then use that to assess the patient. You will not get an accurate assessment. It will be difficult to actually do an assessment at all. So first, a quick thinking on your feet. I always say that if you are in such an area, you have to be thinking on your feet. You got to be quick in thinking. All right. So which part of the body is it? Is it a trauma pain? Do you think it's a trauma pain? Is it a chest pain? What makes it worse? What makes it? What relieves it to some extent? What makes it a bit more bearable? These are things we should consider. When did the pain start? When did it start? And was there any medication taken to make the pain any better? Obviously, if they come to you on the shop floor, then it means something has been done and it's really not helped. Okay, it hasn't helped. Rarely will somebody come and say, oh, I've taken this and it's helped, and they've come back to have it checked. I mean, rarely will you get such a situation. So these are the things we consider when it comes to assessment of the patient, especially when pain is concerned. Is the patient on any medication? I mean, if it's a chronic pain, has there been any medication prescribed over a period of time? If it's actually helped, is it an acute pain? What did you do? Did you report it somewhere else? These are things that we should consider anytime it comes to assessing of our pain. All right, of our patient who may present with pain but not really knowing what the cause may be. Okay, now what else comes to mind? Let's say this is a senior nurse or a senior staff nurse, so obviously you know your staff to some extent, and for doctors, obviously they do know what they're doing. So the patient has been on pain relief, or the patient has taken something for an acute pain and it hasn't helped. This is where drug administration comes in. Usually when we talk about drug administration, it's more centered, or our attention is more on the nurses. Okay, our attention is more on nurses on the shop floor, but doctors do have a part to play as well, and I do know they are trained to some extent when it comes to medication stuff, because let me reframe that. Doctors are trained when it comes to drug administration, because they will not be, they cannot be prescribing medications that have the same components together. Okay, you cannot give co-amoxicillin and amoxicillin at the same time. It's not done. Okay, so that's why I'm saying that we've all had pharmacology training. We all know what drug interactions are. If you do not know, there is always the BNF, there is always the approved medical form, formulary records in your department, so you can always consult or speak with a senior. All right, so the patient has been given medication, has been prescribed medication by a doctor. What sort of medication is it? Now, drug management, briefly, drug management, we all know it, especially nurses. Okay, this is to my colleague, dear nurses. From university, as soon as you are said to be qualified to work on the shop floor, or actually you learn this whilst you are still training. You may not have finished your training, but you should know that we always talk about the R's. Fantastic, great. We should know those are. That is the right medication, right patient, right route, right time, and right dose. I think there is another right somewhere. Fantastic, you should know that. But bear in mind, drug management and drug administration goes beyond that. Okay, it goes beyond your R's. Now, let's say you have been prescribed an IV medication, for instance. Obviously, you cannot give that medication without second checking with another stuff. Things like anti-emetic, depending on which establishment you're working with, or the hospital or clinical area protocol or policies, you may be able to give medications like anti-emetics. I mean, those IV ones, you are able to give that without second checking. But from experience, I've realized that things have changed. Okay, I do not know if it's because I've worked in a few hospitals than a couple. Okay, things have changed. What I have learned, okay, and what I've come to know is this: IV medications are always checked by two trained staff. Okay, two trained staff. If you do not have a nurse readily available to check with you, if there is a doctor around, the doctor should kindly check this with you. Okay? Now, after this has been checked, something as simple as an antiemetic for you to be given intravenously, it's been checked. You can go ahead and then give it to the patient without any issues. All right. But when it comes to pain, usually when an opiate or opiates are prescribed, it has to be checked by two trained staff, properly checked. Okay, you're checking patients in the patient's number, that's registration number, and then the dosage is checked. Everything has to be recorded in the control drug book. If you work in an establishment where you have an approved system of electronic recordings, that is also checked by two trained nurses. I'm yet to work in a clinical setting where a control medication is given by just one trained nurse. I haven't experienced that yet. So if anyone has, please be happy to share. But it's always checked by two trained health professionals. Okay, two trained health professionals, and then you walk to the patient together and make sure that this is the patient, and then administer the medication as approved appropriately. Okay, now you should always remember your aseptic techniques, especially in immunocompromised patients. Okay, in immunocompromised patients, you should always remember your aseptic techniques. IV medications, non-touch techniques. IV medication, non-touch techniques. You do not touch the syringe and you do not touch the syringe, the needles. You know what I mean by non-touch technique. Please, if you do not, go read a little bit about it, but I'm sure in the near future I'll be talking about IV medications. So these has to be prepared properly in a clean environment. Of course, if you work in a setting like ICU, there are procedures. Obviously, you will be using sterile gloves if you have to touch any line that should be catered with the utmost care. I haven't worked there for some time. Occasionally in my clinical practice, if I did come across anyone with those PICC lines and central lines, of course you know what you should be doing. Clean technique, aseptic technique. If the dressing is messy, please change it neatly. Okay, you cannot have a line that is messy and still give medication and expect the best outcome. Okay, so we always have to, even the peripheral lines, if it is murky, it's unsightly, just change it. There is always a VIP, not everybody knows the VIP score, but there is always a documentation process when the lines are checked. If the peripheral line, we know, if it is 72 hours, that has to be changed. That has to be, taken down. It has to go. And usually for IV medications, by then the patients should have had their dosage, unless there is a change in the course of treatment. Then that's a different situation altogether. So please, let's bear these things in mind when we are dealing with our patients. Now, you've given your medication. Any side effects? Do you think the medication has served its purpose? If there has been effective, okay? What was the outcome? All these things have to be documented. I know when you are in a situation where you've got so much going on, patient is crashing, patient is critically ill and all that, you wouldn't immediately give the medication in 30 minutes or an hour, come back to the patient and say, oh, medication given and pain relief, pain subside or pain relief, whatever your documentation processes, your words, your keywords will be. But when you get a chance to actually sit there and do your documentation, make sure you remember to give this, to provide those informations that, okay, you gave this medication and the patient tolerated it well and it's worked. The outcome was what was expected. If that's why the documentation with the drug chart or the whichever method of documentation that works with your environment is important. So if somebody should, they have to cross-check to see if the patient is doing well, or for whatever reason they would have to check if the patient has actually had their medication and it's worked, and you do not happen to document in your patient's note the drug chart, or the drug chart should be able to say that, oh yeah, the patient received this so and so medication at so and so time. Okay, so documentation process is a legal process. Your documentation is a legal document. Okay, so it should always contain what you have seen and what you have done. Always must contain what you have seen and what you have done. Documentation, I mean, when it comes to patients' documentations or patients' document, it's a legal document, so we have to treat them as such. All right, okay, that's just a little, I'm trying not to do this a bit too lengthy so that it becomes boring. Now, you've given this patient monitor, I did touch on it, effect of the medication that you have given, any side effects, stuff like that, but patient's monitoring goes beyond that. Okay, this bit of patient monitoring I'm talking about like patient monitoring in all times. I think I have mentioned it before in one of my vlogs. Patient's monitoring just covers everything. The patients may not be ill when you first found the patient, but your monitoring would actually curtail so many things. Your monitoring will actually make things easier for you. Okay, if you keep an eye on your patient, talk to your patient when you get the chance. If they are deteriorating, you would know. All right, you would know if the patient is about to deteriorate, because when you first came in, let's say when you first came in on the clinical setting, you've seen this patient, you interacted with the patient, patient is fine, and then as you're walking about, you're still communicating with your patient. When you get a chance, that helps. I'm sure I'm not saying it is, this was one of the rationale behind that rounding charts we've got. That rounding charts, when the healthcare associate and HCAs would have to document, and you the nurse, if you get a chance to document, if the patient has had some water, if the patient has been comfortable. I think it's done every hourly or so. That's the rationale behind it, to curtail the number of preventable clinical incidents. All right. So you're passing by, patient is on a cardiac monitor. The nurse looking after the patient is busy with another patient, right? You happen to just look up and you see the cardiac monitor. Reading is kind of a bit funny. Let's say you try to talk to the nurse is too busy and can't talk to you. Patient is lying down. Go close to the patient. Check if the leads are on properly. Go close to the patient. Check if the leads are on properly. If the leads are on properly and the reading is still funny, then you can go ahead. I'm sure you would have mentioned it to the nurse if the nurse is inside. And then talk to the nurse to me. Why am I saying patient instead of nurse? Talk to the nurse and find out what actually is happening. If that has been the reading for some the tracing for some time, and if the team is aware of it, or if the nurse in charge, the superior, is aware of what is happening. If not, prompt them to do so. If they are too busy to do so, and you can see a doctor or a senior nurse on the shop floor, let them know what's happening. Could be that the patient is about to go into cardiac arrest or something. You know what I mean? If it's in sinus rhythm, we all know it's in sinus rhythm. AFib is, well, if you don't know what should be expected on a cardiac monitor, nearly every trained nurse knows that this is sinus rhythm. If it's a brady, you know it's brady. Tachy, you know it's tachy. At least those simple ones, we should know them. We should know those ones are quite terms, or those ones are quite how do I put this? Those kind of readings are something I expect every nurse working with a patient to know. Bradycardia, sinus rhythm, tachy, you should know. Every nurse should know. No one is saying that every nurse should know if there is ventricular tachy, AFib, No, those simple. If it doesn't seem right, just find out. Is that what it's always been? And is this what the team has agreed on? Because for one reason or the other, the patient may have come in with a cardiac history, and possibly that's what it's going to be for the patient at that particular moment. So there's nothing that can be done. There's no harm in finding out, or just prompting someone, or letting somebody know that, oh, this is what you found, or is that what it has been? That's what nursing is all about. Yes, you train as a nurse, you learn all those things, but sometimes it's just what makes you a good nurse is just those little things. Those little things you pay attention to. That's what makes the difference. And you'll be surprised how much the patient loves such care and attention to details in this context when it comes to nursing. Now, I did say communicating what you've seen, any concerns, or what you think should be looked at to someone. The way we do it also is important. You could be the senior nurse, okay? You could be the matron. And the other person could be the junior nurse working. I'm telling you, they work hard. They do work hard. It's a lot. It's a lot being a junior staff, okay? A junior staff. I'm not going to mention bands because this band doesn't work globally. But it's hard being a freshly trained RN and then trying to work your way up. the way you do it makes the person feel that, okay, I'm actually valued. I'm actually part of this team. Communication, we say things, but the way you put it, the tone, your choice of words, they all form part of communication. It's fine. For you being the senior nurse or you being the matron for that particular unit, your presence alone is intimidating. So the way you come across with your to your staff, the way you communicate with them will make them feel valued. Can you imagine the way you do it? And when they are working, I mean, if you're a junior staff and your matron or your manager has a good rapport with you, and you go on the shop floor and mess up intentionally, then you be something, Papa. Now I had to say that. But if you do know what your responsibilities are as a nurse, remember duty of care, the condom we always talk about, and you are on the shop floor, you will make sure that you do whatever you can as a nurse to make your patients happy. It makes your work easier. You do not want to go there and then be running around when you shouldn't be running around. Okay? I just had to chip that in. So here, communication, very important. It comes under documentation as well. Okay, communication comes under documentation, or documentation comes under communication, whatever. So what you put down is what it should be, what you've seen and what you've done. Okay, same way when you're communicating with your patient, when you're communicating with your colleagues, when you're communicating with your seniors, our choice of words, the way we come across when we are explaining things. Yes, sometimes tempers can be high, especially as some settings when everything has to get done. I mean, things can flare up. Okay, voices are raised, and if you can, try and apologize. I have been in that situation. That's what I'm saying. That's because sometimes you just want to get something done, save a life. And in situations like this, tempers may rise. And surprisingly enough, we've kind of adopted this. Maybe it's the area I have worked. Oh, yeah, I have worked. I don't know if I'll be going back in the near future, but let's see. It's we kind of have accepted that, okay, in situations, things like voices are raised. Yes, that's why we do team breathing after such incidents, debriefing after such incidents. They are very, very important. So thank you so much for listening to me. My name is Janet, and this is the Kosh TV. And as I always say, this channel is backed by a group of people who are still shuffling their feet, the Kente of Expert Club International. And we aim to improve the well-being of individuals and the family as a whole. Remember, you and your community are responsible for your well-being. So let's all make it a point to make a positive influence or impact wherever we are. So I come your way again. I say, stay healthy and bye-bye. Remember to share and comment.